Okay, great. Thank you everyone for joining the Nearman Practice Management webinar. This evening, we have a phenomenal speaker with us here to share a really interesting and exciting topic. We're all just thrilled to hear about this. The webinar is sleep-related breathing disorder and pregnancy. So we have with us here Dr. Steve Lamberg. I think looking at the attendee list, many of you probably already know Dr. Lamberg, but for those of you that don't, Dr. Lamberg practices in Northport, New York. He is the inventor of the Lamberg Sleepwell oral appliance and also a faculty member of the Nearman Practice Management Dental Sleep Medicine Mini Residency for 2022. That mini begins July 29th and 30th in Jupiter, Florida. We'll tell you a little bit more about that later, but Dr. Lamberg is just a perfect speaker for, well, this topic and many others. He's a diplomat of the AADSM, member of the AASM, AGD, AACD, and this is just listing a few, by the way. He's also launched the Pediatric and Adult Airway Network of Long Island, also known as PANI, as well as the scientific advisor for COIS. He also hosts seminars to help dentists launch dental sleep medicine right into their practice. So welcome, Dr. Lamberg, and thank you so much for taking the time this evening to impart this amazing knowledge.
Yes, thank you. Thank you.
Thanks, Rose. Thanks, Courtney. It's a pleasure to be here. It's an honor to be here. Thank you very much for inviting me. This is a topic that I think is super important. And I got into this probably in the last year or so. I got interested in this topic and had a kind of a challenging debate at a dinner party back in November. And I decided I really need to become an expert in this field. So I started collecting a lot of literature. And as it turns out, there's a lot of literature that just came out in the last 6 months. And I put it together into this program for everyone tonight. So you will get a lot of literature that's within the last month or two. And the topic is sleep-related breathing disorders during pregnancy. And it's not just the impact of on the mother and the fetus, but it's also, what about if we intervene? What about if we do screening and evaluation of the mom, the pregnant mom? And what if we intervene? Is that going to make a difference in maternal and fetal health outcomes? And the reason for that need to know that is insurance isn't going to pay for anything unless there are positive health outcomes from the intervention. So we need evidence for that. And I'm going to show you today through a lot of articles and through just explaining how the physiology works, you will understand and appreciate how it all connects and why insurance should pay for it, and the importance of this going forward. Just before I do start, I will tell you the OBGYNs in my area are very slow to get involved with this. They believe it's an important issue, but just like all the other physicians, they have their protocols and they've been trained a certain way and they do things a certain way and they have a certain RVU, relative value units, that they have to produce every day. So it does take time. It's sort of like swimming out to a cruise ship to push the bow and change the direction of the cruise ship. We have to kind of be patient and understand, appreciate that these docs are very bright and they've been helping a lot of people for a long time. And this is just another piece of the puzzle. Word here. I'll tell you how this all got started. In 2011, I wrote a questionnaire, and the questionnaire was as a result of studying for my boards, my sleep boards for American Academy of Dental Sleep Medicine. And I found out that there was an odds ratio of having all these diseases if you had obstructive sleep apnea. In a few articles, it showed the flip or the reverse of that. It showed that if you had certain diseases, that the odds ratio of having sleep apnea was X. It increased the odds ratio of having sleep apnea. So I put together a small bunch of categories. There were about 5 or 6 categories at the time. Dr. Carstensen, who at the time was the editor of Dental Sleep Practice, published the article. He loved the idea. And over the last 11 years, it grew. And now I'm on version 15 of this questionnaire. It's a 1-page questionnaire. And as you can see, it covers cardiology, pulmonology, gastroenterology, neurology, endocrinology, otolaryngology, and then it covers urology, dentistry, psychology, rheumatology, dermatology, ophthalmology, chronic pain, hepatology, oncology, and look at number 17, chapter 17, or category 17 is obstetrics. And then there's nephrology, and then pediatrics for the kids, which we don't really use this as a scoring tool. It's an education piece. And it's because a lot of patients either have relatives or neighbors that are kids. So we want to kind of educate them. So the screening tool here is also an education piece as well. 3 years ago, Dr. Coyce out in Seattle said to me, Steve, I love the questionnaire. I want to use it in my curriculum at the Coyce Center in Seattle, but we need you to write a key, an interpretation key. Why did you ask those questions? And I said, I asked the questions because there's an increased risk. He said, I want you to explain that in a questionnaire. So I went home after being at one of the symposiums, and I started writing it, and I realized it was really too long. It wasn't going to be 3 or 4 pages. So I decided to write a book. So I wrote a book, and it's called Treat the Cause, Treat the Airway. And every chapter in the book represents one of the categories in that screening questionnaire. It's a very easy read. It's meant for your patients. It's meant for other physicians that aren't exposed to airway problems. And I'd highly recommend it. Obviously, it's a simple read. Each chapter is about 3 pages. It does have a lot of references. More than half the book is references. And you don't have to read those, but they're there if you're really interested in getting where the evidence came from, it's there. So getting into the meat of the lecture, now we're going to talk about the maternal fetal outcomes. I don't know if anybody saw the movie Don't Look Up with DiCaprio. It's a very funny movie. There's a comet that's coming to slam it to Earth, and there's a bunch of people that are actually resisting this whole movement. All the astronomers know with 100% certainty that this comet is going to hit Earth, and you can't believe it, but people are putting on sunglasses and they're not looking. They just don't even want to look up. They're just trying to put their head in the sand, just like an ostrich. So Don't Look Up is the name of the movie. It's a funny movie. It's very fun. It's a satire really about global warming. I'm going to steer clear of politics in this seminar, but Don't Look Up is the name of this lecture. But if we did look up, we would see that pregnant women diagnosed with obstructive sleep apnea are at a higher risk of having adverse maternal and fetal outcomes. And if we did look up, we would see intervention can lead to better maternal outcomes, better fetal outcomes, and better outcomes for the newborns, including their growth and their development into adulthood. That is a big piece, and we're going to show you some articles on that. So let's get down to the gritty stuff here now. Pregnancy issues contribute to airway problems. You probably know most of this, that it's an increase in progesterone, which causes vasodilation, enhances respiratory drive. There's a vacuum effect that increases the airway collapse. Estrogen, vasodilation, causes edema and swollen mucous membranes in the nose. Rostral fluid flow. You lie down at night and the women have a lot of airway edema, and that makes breathing more difficult. There's weight gain, which makes breathing more difficult. Lung volume is decreased, and that's because of the fetus on the lungs. There's an increase in O2 consumption, increase in tidal volume, plasma volume, increase the blood pressure, cardiac output is increased. Mechanical forces of pregnancy cause stretching of the chambers, which lead to arrhythmias and increased heart rate up to 20 beats per minute. So we know that pregnancy causes a lot of stress on women. Women know that, men not so much. Airway problems contribute to pregnancy issues. So we have hypoxia, we have increased sympathetic drive, we have increased fragmented or interrupted sleep, we have increased inflammation. These are airway problems that contribute to the pregnancy issues. Now, when they happen together, it's even a bigger problem. Independently, both pregnancy and sleep apnea contribute to inflammation, oxidative stress, and upregulation of sympathetic nervous system. When they happen together, OSA is associated with hypertensive disorders of pregnancy and gestational diabetes. I want to step back for one moment and just review, because it's very important to understand the inflammatory response. We have acute inflammation and we have chronic inflammation. Acute inflammation is good. We need inflammation. It helps us heal. So the immune system has the pro-inflammatory cytokines, and they go to the local site and they help repair. Chronic inflammation, when you have the cytokines all upregulated, that's what leads to medical conditions. So basically, we have a situation where there's chronic inflammation from the pregnancy, from OSA, and we know that pregnant women with obstructive sleep apnea had significantly higher levels of all these cytokines and inflammatory markers compared with women without OSA. So there's a significant correlation between systemic inflammation and respiratory OSA events. Systemic inflammation during the third trimester is actually inversely correlated with neonatal birth weight and newborn gestational age. So that's an important thing, and we're going to show you the odds ratios of that. So let's just review some of the fast facts, I call them, because they're just little factoids that are out there that are established in the literature. Pregnancy, as in menopause, women have an increased risk for sleep-related breathing disorders attributable to changes in their hormones, as well as weight gain and rostral fluid flow and lung volume changes. Obese pregnant women have 20% of them have OSA, and sleep-related breathing disorders are associated with hypertensive disorders of pregnancy, occurring in 10% and possibly much more in pregnancies. And the prevalence of OSA was estimated to be 3.6% in early pregnancy, and it increases across gestation with rates as high as 30% in the third trimester. And that was a European study that showed the 30 percentile. OSA in pregnancy also increased the risk of cardiomyopathy. Look at the odds ratio. The OR stands for odds ratio, or the risk factor. So there's 9-fold the amount of cardiomyopathies in pregnant women that have OSA. And that's not good, you know that. Adverse maternal outcomes. Pregnant women with a diagnosis of OSA at delivery, they were significantly increased risk of having cardiomyopathy, congestive heart failure, pulmonary embolism, and hospital death. So adverse maternal outcomes. Now, this is just a little chart I put together, and there's a bunch of references in the bottom. But preeclampsia, the odds ratio up to 5.4 in some of the literature. Eclampsia, that's with seizures, 4.1. Cardiomyopathy, odds ratio of 9. Postpartum hemorrhage, 1.4. Venous thromboembolisms, up to 4.5. C-sections, 2.1. Metabolic syndrome, 1.5. So it's a very high increase in risk for all these other medical conditions. When the apnea-hypopnea index was over 5, persisted postpartum, these women developed metabolic syndrome, 2.5 times those that didn't have OSA. They also had insulin resistance, up to 31% in Europe. And then there's pregnancy-induced hypertension, 2-fold. When the AHI was over 5, persisted postpartum, odds ratio of 3.7 for hypertension. And in late pregnancy, OSA had depression scores, odds ratio of 8. There were also respiratory complications and maternal death that's in the literature. So in May, last month, this article came out about sleep-disordered breathing in pregnancy and after delivery. So this is risk factors again for the mother. Obstructive AHI over 5 in pregnancy had increased risk of metabolic syndrome. And when the ODI was over 5, had increased risk of hypertension and metabolic syndrome. So these are easy things to get a handle on. We can screen for this very simply. And we're going to talk about screening. So now I want to just turn this over a little bit and look at the flip side. Let's look at the fetus, the impact on the fetus of the situation here when the mother has obstructive sleep apnea. And by means of review, the umbilical vein, you can see the cord is a vein and an artery, and you have the vein, which goes to the heart, and that's supplying the nutrients and the oxygen, albeit a little bit on the hypoxic side. There's low oxygen levels, of course, already going to the fetus because it's already been through the woman. It's returning to the heart and lungs, and this blood is now going to the fetus. There's less oxygen in that already. And then the umbilical artery goes out back to the placenta. And we're not going to get into that deeply. I just wanted to just touch on that a little bit. And let's look at the fast facts regarding the adverse fetal outcomes. So Preterm birth, the odds ratio of that were almost 2. And the risk for psychological development issues increased and increased orthodontic needs. There were congenital abnormalities twice as frequently. Low birth weight, 1.67. Okay, preterm births, 10%. Low fetal growth restriction, FGR, this is about 10%. And that's associated with decreased fetal activity, which is commonly looked at by the OBs. They look at fetal activity. The 5-minute APGAR score, most people know about APGAR, was less than 7, the odds ratio of 2. So that's not good. Stillborn or perinatal death was twice as common when the woman had obstructive sleep apnea. Neonatal nursery admission, 1.9. And here, 8, 9, and 10 are really relevant to the dentists in the crowd. Malocclusion, the deep bite was the most common. Malocclusion was crossbite. There was class 2 occlusion, delayed eruption going forward, and the palates were narrow and deeper. So they were high arch palates. And this is really common in the newborns and also the developing children when their mother had sleep-related breathing disorders. They also had difficulty speaking and chewing. Fetal hiccups were reduced in women with preeclampsia. Fetal hiccups no one really knows what that's about, but it is hypothesized to be helping the child learn how to swallow, chew, and use all the perioral muscles properly. So the fetal hiccups were reduced when the mother had sleep-related breathing disorders, which is not good. And then when they put those women on CPAP, they found there's evidence in some of the articles that showed that the fetal hiccups increased again. So that was an intervention and it showed a positive health outcome. Then there's increase in tethered tissue. So that has to do with apoptosis. And normally that web underneath the tongue behind the anterior lower mandible, that lingual frenum normally is not a problem, doesn't tie the tongue down, but sometimes it does. And that's when there's a failure of apoptosis. Those cells are supposed to have a programmed death and not be there. And that's related to hypoxia inducible factor, which is more prevalent in sleep-related breathing disorders of the mom. There's also gestational intermittent hypoxia, and that leads to metabolic dysfunction, increased weight, and adiposity index into adulthood of these are the fetuses, but now there's an impact into the adulthood, like I was saying before. So in April, going back 1 month from the previous article, very preterm and low gestational age, immature sucking reflex at birth impedes the growth. And the high arch palate and posterior crossbite share a non-nutritive sucking habits as a common risk factor. This study is it shocked me, and it was really interesting that they even did this study. It was just published in March, and I'm kind of going back 1 month at a time here. They investigated the relationship between fetal growth patterns and blood pressure in adulthood using novel modeling techniques based on ultrasound. They measured the size of the head and the chest of the fetus, and the largest prospective cohort of pregnancy and childhood and adolescence and adulthood carried out in the world ever. And it provides a better reflection of fetal growth. There were 1,440 fetuses that they measured and then followed them into adulthood. Babies whose head and abdominal growth during pregnancy is below average are at a greater risk of hypertension during adulthood, with their systolic blood pressure 3.5 higher, which confers a 10% increased chance of death due to heart disease and a 10% increased chance of stroke. So this study gives fuel and provides new evidence that there are different patterns of fetal growth and that they play a critical role in predisposing the offspring to risk of future heart disease and stroke. So this is the don't look up part. We have evidence, 1,400, and N of 1,400 is very convincing to me. Even without OSA, repetitive upper airway flow limitations in pregnancy are associated with surges in nocturnal blood pressure and poor maternal and fetal outcomes, and may be just as detrimental as frank apneas and hypopneas. And this refers to like the UARS patient, upper airway resistance. So if they don't have a DSAT, they could still have fragmented sleep and turn on the whole sympathetic nervous system. Additionally, there are other pathways to have subcortical arousals, and if they don't have cortical arousals, they're not counted as hypopneas and apneas. I'll show you a graphic here, but I don't want to confuse anybody too much, but there are sensory afferents all over the bodies, baroreceptors and chemoreceptors, lower esophagus and the carotid sinus and the carotid body. if they have to be diagnosed in order to treat the airway. So they'll have to have a sleep study, and then the OB or the sleep doc will have to say, yes, they need to be treated. And then you can go ahead and make some type of appliance. But the whole idea of it, if it's in the second or third trimester, you can't wait 3 weeks to get an appliance. So you need to make a temporary appliance quickly and inexpensively. And so these are all good questions. And I hope to have more on it next month.
Abby says, let's be the first.
That's great.
That's right. I like that.
Cool.
Okay, awesome. Well,
Is that it?
Yeah, I think that's it. Thank you, as
Sounds
always. Thank you, Dr. Lamberg. We always
Thank
enjoy
you.
your webinars. You are always
Yeah.
bringing just amazing information to the table, and we just are very grateful for your time. So we'll see you. Goodness, countdown. It's just over a month away now.
Month away. Looking forward.
All right.
Bye.
Bye, everybody.
Thank you,
Hope to see you
Great
in
night.
Denver.
Everyone have a good evening. Thank you.
Good night.
Bye-bye.